real consequences. Okay, so this is a question I get asked every time I speak about DCD. I often get asked this: is dyspraxia the same as DCD? So yes and no. Okay. I like to think of them as being synonymous. I know that when people talk about dyspraxia, for me, they're talking about DCD and vice versa. But there are some fundamental differences. Okay, so DCD is a formally defined condition. Okay, it's in the DSM-5, whereas dyspraxia, on the other hand, it's more loosely used. Okay, it's not an official diagnosis. For me, dyspraxia as well also differs in terms of the scope of use, in that, so when you're not using dyspraxia in the context of DCD, dyspraxia also has a broader meaning. Right? So as health professionals, we use the term dyspraxia to describe movement difficulties that can happen to people later in life, okay, because of brain damage. So for instance, we can describe somebody who's had a stroke as having a movement that is dyspraxic. There's also sort of a regional preference for the terminology. Dyspraxia is the favored term in the UK, where there are lots of sort of NGOs that have been established. But in North America and the rest of the world, Europe and Australia, the term is DCD. Okay. And, you know, DCD has now been around for quite some time, since 1994. And most of the research published since then have used the DCD terminology. Okay, so most researchers are using it. And even a lot of professionals now refer to DCD, especially when talking about the diagnosis. Now, when we talk about movement in children, or adults for that matter, with DCD, it's not just about being clumsy, right? Their movements can be described as inaccurate, it appears awkward, it's not smooth. Let me just see if I can do this. And get the video. Okay. Need the sound. Yeah, so it appears awkward, it's not smooth, and it's inaccurate. Okay, and the more complex the task, the more these difficulties show up. It takes so much extra physical and mental energy to do the things that other children without DCD can do without even thinking. Okay, so like climbing stairs without tripping, catching a ball comes easier. So it's really hard for these children, and I often imagine how exhausting that must be, you know, day after day to be trying so hard. These children often fall a lot. They bump into things and knock things over. It's not carelessness, it's a real struggle, okay, with spatial awareness, which is the issue. So they might drop objects frequently, they misjudge distance, and this can be frustrating not only for them, but also for parents and adults around them who don't understand what's going on. Another key feature is difficulty with transferring movement skills to new situations. So even if they've learned how to do something in one context, for example, you know, playing cricket or rugby practice at school, they might not be able to do it in another situation, like sort of at a match, for instance, okay? So transfer is poorer, or they've learned to do something in the therapy room, but that doesn't always transfer into the classroom. They also tend to be slower, have trouble planning and predicting movement. And I think that is one of the key sort of underlying mechanisms related to DCD is the lack of internal modeling and the ability to predict movement. And sometimes they move in ways that are fast, but inaccurate. And I'm sure you can picture these kids that they're always zooming here and there and, you know, wanting to rush through things and get it over and done with, but end up with huge sort of inaccuracies and making lots of mistakes. DCD is a lifelong condition, okay? It's not something you outgrow, like the other neurodevelopmental disabilities. You learn to grow with it, okay? Some people learn to laugh it off, like myself. I still struggle to do parallel parking, and you wouldn't dare see me in any kind of formal Zumba or dance class at all, okay? So you learn to laugh it off, you cover it up, and you can basically get through life, by hiding. But many children, and I think this sort of comes as an adult, I'm a over 40-year-old woman, I don't care anymore, but the kids feel really isolated and depressed. And that is why early support is so important, not just for their motor skills, right, but for their emotional well-being, which I think is actually one of the most important things. And over time in these children, you see a pattern, okay? So it often starts with, oh, but I can't do it, Mom, I don't want to, I can't do it. And then sort of they become defiant and say, well, I can't do it, I'm not going to do it, I won't do it. Okay, they start to avoid the task they find difficult, not because they're lazy or defiant, it's because there's repeated failure. Because when they do try, they fail, all right? And this repeated failure has taught them that it's not safe to try, okay? That for me is very heartbreaking, and it's something I see in my own children. But it is something that I think we can change as adults by, examining our own attitudes. And there's some strategies I'll share with you later to kind of try and break this cycle. Okay, let's talk about the physical health consequences of DCD. Children with DCD tend to be less active than their peers, okay? And this then leads to a cascade of issues. So lower fitness, poor balance, and reduced strength. And this you'll find across sort of lots of the research papers out there that they present sort of like this. And there have been a few long-term studies that looked at how children change over time, and they become overweight. They already start to present in adolescence with obesity and even metabolic disorders, okay? And these risk factors, this reduced physical activity and the reduced physical fitness level, it's going to track into adulthood. Because if you have not been a physically active child or enjoyed fitness activities, you're not going to do it as an adult. So while, early intervention for the motor coordination problems are important, it's not just about motor coordination. It's about their lifelong health. And this is what makes DCD serious. Beyond the physical health, DCD has a major psychosocial impact. Kids often experience low self-esteem. They've got decreased social interaction with peers and poorer mental health outcomes. Okay, their quality of life is also significantly affected. Lots of studies to back this up. Children often feel isolated, misunderstood, discouraged, especially when their difficulties are dismissed or overlooked, and they referred to as lazy, defiant, and all the other negative things that that people say about, because they don't have a very obvious disability. So DCD is, I think, a lot more common than many people realize. Globally, it affects 5 to 6% of children. Okay, and that is not an insignificant number. That's quite substantial. If you look at the average classroom in a public school, for instance, you'll probably find, one child in every classroom that has DCD. So it's definitely not rare. But the rates vary by region, and of course also sort of there's methodological issues in the research about sort of why they get different prevalence rates across the regions. In sub-Saharan Africa, we've got no information about DCD, but we know that the prevalence of neurodevelopmental disabilities are quite high, okay, so in general. But the numbers tell us that DCD is not rare. It's not something we can afford to ignore. And I just highlighted sort of 2 studies that were conducted looking at prevalence in South Africa, one from the Free State and the other one from the Northwest Province, which again reported high, sort of 10% of grade 1 children between the ages of 6 to 8 years present with signs of DCD, which is here referred to as PDCD. Okay. Yeah, often you'll find PDCD or SDCD, suspected DCD, because children who participate in these large epidemiological studies, they really sort of meet or are able to meet all the DSM-5 criteria. I'll tell you some more about that. Okay, what causes DCD? There's a huge genetic basis for DCD, and I was at a conference earlier this year where there was lots about, you know, the genetic links, and people spoke about chromosomal deletions and mutations. I'm a simple physio, these genetic things go over my head, but there are papers out there that have sort of looked or examined the genetic and hereditary influences. But let's look at the risk factors though. And the strongest evidence points to what we see classically across all the neurodevelopmental disabilities. It's the male sex, preterm birth, and low birth weight. These preterm children are 6 to 8 times more likely to be diagnosed with DCD by the time they hit school age. Okay, and other factors, maternal smoking, low socioeconomic status, have all been associated with DCD. So in some ways, it's very similar to cerebral palsy, but it's a lot less consistent, okay? But the key message here is that, you know, if a child's had a very difficult start to life, we need to be extra vigilant and sort of look out for things. Okay, so getting to the official diagnosis. The DSM-5 defines DCD using 4 criteria. So first criteria is that the motor skills deficits, that the children struggle with tasks that should be easy for their age, okay? But also, I want to highlight the fact that it would be below what would be expected for the child's age and experience. Okay, so granted they've had the opportunity to learn a particular skill, you know, you can give them that DCD diagnosis. And this is something that I picked up in my PhD studies some years ago in the Cape Flats. And we were just so astounded by the large numbers of children who were performing poorly on our standardized assessments. But of course, the children, context matters, right? So the children living in those areas had very limited access to resources. They were on the Cape Flats, parents kept them indoors because, you know, the shooting of the gangsters and that kind of thing. It's just not safe to send them to the park to play. So of course, the motor performance is going to be affected by this. And so for those of you working in public settings, context really matters. So I hope everyone knows that, you know, use your clinical judgment, and that standardized tests are not going to tell you whether a child has DCD or not. Because the second criteria here is that the difficulties, these motor difficulties, interfere with daily life. Okay, so from your dressing in the morning, doing schoolwork, playing sports, all those types of things, it must interfere. The third criteria is that symptoms usually begin in the early developmental period, usually before the age of 5. And this is something new that was added into the revised version of the DSM-5. My dates, I don't know, because there are usually signs. And parents, you know, if they reflect back, can think about some of these delayed milestones, lack of eye tracking, limited exploration of the environment, those kinds of things. So if you ask about it, it might trigger, okay? And then, of course, you have to exclude everything else, okay? You've got to rule out intellectual disability, visual impairments. So it's really a comprehensive definition here that the DSM provides us to guide diagnosis and support. Okay. as I said, DCD is a lifelong condition, and the challenges change, okay, but they don't disappear. We see difficulties across physical, cognitive, and psychosocial domains. And that means our support must be ongoing, it must be adaptable, and it's not just a one-time thing that happens in childhood, but we need to continue supporting these kids over the lifespan. So what do you see at 3 to 5 years or preschool age? The signs are becoming quite obvious at this point. All right, so beyond the delayed milestones in your 2-year-olds and under, you're going to see clumsiness, delayed fine motor skills and poor coordination, tasks like getting dressed, doing up buttons and zippers, doing your hair, making a braid, those kinds of things. Playing in a jungle gym can be really tough. And these kids might avoid physical play, not because they don't want to, but because it's just too hard. And they often get tired quickly, your little toddlers, which can be mistaken for laziness or lack of interest. It's the toddler who's not climbing on the jungle gym in the play area, but rather sort of sitting in the ball pit and throwing balls around, okay? Many children at this age do express feelings of being like bad at something, being bad at the game, and then they avoid playing. There's frequent frustration or emotional outbursts, especially when they're asked to perform a motor activity with accuracy. They have difficulty following multi-step motor instructions, like first jump, then spin and clap. And these are the kinds of things that they're doing in the preschool classrooms. They're playing music, and my kids did something called monkey gymnastics when they were young, and these are the kind, they will have difficulty with these multi-step motor instructions. They have poor imitation of motor sequences and a rather inconsistent performance. Now, I have to make this note and disclaimer that diagnosing DCD before age 5 is tricky, okay? There's a lot of normal variability. Some kids are just late bloomers, but if a child consistently struggles with motor tasks, despite having plenty of time to practice and no other underlying issues, we must start monitoring, okay? So early intervention, even without this formal diagnosis, can make a big difference. In terms of the 6 to 8 year olds, okay, this is the age when children start going to school in South Africa, and the demands on them, on their physical capabilities are increasing, okay? So now they're in a classroom and they're learning to write properly. From 8, they're doing cursive, I think, or 9, cutting, drawing, and they are tying shoelaces, okay? So they might present as messy eaters, poor ball skills. They find PE overwhelming, okay? And learning to ride a bike can be a massive challenge. Socially, these children avoid the playground games. I know my children are at schools in the southern suburbs, and one of the most popular games that I see them playing in the morning and when I pick them up is hand tennis, and they all stand in a circle and they bounce a tennis ball in between them. And this is something that, children just avoid who can't do it. So they avoid these kind of games, not because they don't want to play, but because they're afraid of failing or being teased. And unfortunately, teasing and exclusion are common, and this leads to frustration and withdrawal, and then like a growing sense of not belonging. So DCD is typically diagnosed. Sorry? Hello?
It's in the fridge.
Oh.
When am I going to tell you meat? A lot of water.
Hello, can everyone hear me still?
Somebody was just unmuted, Gillian. Please go on.
Oh, thank you. Okay. So between the ages of 6 and 8, this is when sort of around the world DCD is typically diagnosed, but not in South Africa. Sometimes parents and teachers notice that something is off. And, you know, the teachers tell the parents. I know in many schools they have resident OTs who offer free screening, you know, in these early foundation years. And, you know, they pick up on things. But many parents also, and some pediatricians will rather you know, it gets dismissed rather than sort of being referred to a developmental pediatrician, for instance. And that's a missed opportunity, because if we can catch it here, you know, you can start your interventions. That will really help. Now, the 9 to 11 is what I like to call the missing middle. Okay, these 9 to 11-year-olds are the ones who are falling through the cracks. It's often the age where occupational therapy in schools maybe stops or slows down. The parents have had 3 to 4 years of OT, and, you know, it's time to give the child a break. But the motor challenges at this age becomes more evident in now that school is a bit more structured. Okay, so in class they are slower, they're less accurate. So copying things from the board takes a long time. Organizing their books and pencils and all their project things it's really tough. And they may still be struggling with things like changing their clothes. You know, I know my daughter struggles to change into a hockey outfit, takes extra long when they have to change for sports. And things like, you know, you still see them knocking things over, avoiding sports and tiring really quickly, you know, during tasks like when they have to write a lot because of their poor posture and fatigue, you know, postural fatigue. Socially and emotionally, this group is now starting to feel the pressure. And that's why, you know, I feel a little bit more sort of empathetic towards this group, because they might dislike sports and feel less confident. They're struggling to keep up with the written work. But, you know, these kids are bright, okay? There's often a notable gap between their verbal and their written abilities. And that can be quite frustrating for a child who's still needing to write reams and reams in a classroom. And so you might see an increased anxiety and sort of reluctance to go to school. And sadly, these kids are now beginning to internalize the negative feedback from peers. Why are you so slow? Why can't you do the things? From the teachers, you're just lazy. Come on, you know, get onto it. And even parents, you know, will get frustrated. And the internalization of this negative feedback is what leads to the poor mental health outcomes later in life. Roshaan, can you give me a time indicator, please?
It's now 25 to. We're still good for time.
Okay, still good for time. So just speeding through the 12 to 14-year-olds, you know, now they're in high school, early adolescence. So tasks like note-taking, if they're doing lab work, chemistry, or, you know, those types of things, they're often slower at getting their physical tasks done. So, you know, when you're a teenager or what do they call these tweenies, 12 to 14-year-olds, they still can't make their beds properly. And they're still taking long to get dressed in the morning. And, you know, more seriously, they're withdrawing from sports or dance classes because of their poor coordination. And all these motor challenges can interfere with their independence and academic performance. They have challenges with time management, organizing, but the heightened self-consciousness and social comparison is something we need to look out for. They may experience bullying and isolation, and this, again, like I said, leads to poorer mental health outcomes at this young age. Okay, let's shift gears and talk about assessment. So identifying children with DCD isn't just about noticing the clumsiness. Okay, it does require a structured approach. And we need to look at motor performance, the functional impact, developmental history, and we need to rule out the other conditions. And we need to use sort of the right tools. Criterion A is about motor skills deficits, okay? And we need to measure and not guess. Okay, and there are several standardized tools that are there to help us and give us objective data on how a child is performing compared to their peers. So I've listed a few there, and I say this with not a pinch of salt, but a cup of salt. None of these instruments have been validated within the South African context. And this needs to be, again, kept in mind, but there are things that, they advise us to use. Again, clinical judgment, not standardized tests is what matters. You can use the gold standard as the movement ABC. There's now a movement ABC3, advanced from the movement ABC2. So it goes all the way up to 25 years old now, which is fantastic for identifying sort of young adults. It still assesses manual dexterity, aiming, catching, and balance, although there's some new items that have been added to the manual dexterity and the balance. And this is widely used in clinical and research settings to diagnose DCD and to monitor outcomes. I know quite a few therapists own movement ABC. It is super expensive. And now they're hearing they must buy the movement ABC3 when they all have the movement ABC2. Yeah, it's really, the challenge is in terms of the expense. I must say though that the movement ABC3 is better. Okay, so if you can afford to get one, it's better because the norm reference sample is larger. Again, not South African based, but previously it was only children from the UK. Now it includes New Zealand and Australia. It also includes children from low income contexts, and they also sampled lots of refugee family children who from low socioeconomic contexts were included in this sample. So I think it's maybe a bit more comprehensive. Okay, so that is the movement ABC. Okay, the other one that is also most popular is especially in North America, in the USA, the BOT. It's also been upgraded to the BOT 3. And it now covers children up to the age of 21. Fine motor control, it assesses a few more domains than the movement ABC, but sort of consequently the administration is much longer. Then there's a questionnaire that it's really nice to use called the DCD-Q. And this can be given to parents. It's a parent report screening tool, valid for children ages 5 to 15. It's been translated and validated into many different languages, although still not in South Africa. It's not diagnostic, but it's a great way to flag children who need further assistance. Speaking to the pediatricians and the GPs who and OTs as well. So for ADHD, we have the Connors form that people are required to fill in. The DCD-Q is just as quick and fast, and it's a nice start to see what you're dealing with. And then I must have a special note on the PERFECT. This is something I was involved with in the creation of this tool. It's called the Performance and Fitness Test, and it measures motor performance and physical fitness. We know that children with DCD struggle with both balance, coordination, physical fitness, etc. Okay, and this tool is free. Okay, it is cost effective. You don't need much equipment. You can use it for big epidemiological studies. You can use it in the clinical setting. And the kinds of activities are focused more on real world tasks. Okay, so unlike the movement ABC, when they're asking you to thread beads, children don't thread beads anymore so much, but that this is real world sort of motor tasks. It's less standardized, it's new, it's not diagnostic on its own. So, use with caution, but it's something nice that we can start trying. Just a quick note on criterion A and the diagnosis for establishing criterion A. Again, I said context matters, but also children are spending so much time in front of screens, right? So the slide reminds us that when we assess criterion A, we must consider the child's opportunities for motor learning. So for example, if a child is spending 6-7 hours a day on a screen and 6 hours sedentary in a classroom, that's like 9 hours of no movement, okay? And so when we see motor delays, we must ask, like, is it a disorder or is it the lack of opportunity to move and practice? So yeah, just something to think about. Criterion B is all about how motor difficulties interfere with daily life. And we assess this by looking at the daily living skills, school participation, school performance. And here you can use tools like the DCD-Q, again, the movement ABC checklist, and the listening for DCD guide. But we can also rely on our clinical judgment, okay, combining the test results with, your normal intake interviews and observations to ensure the difficulties are in fact persistent and not just situational. Okay, the listening for DCD. I've just put a little link down below. Maybe I'll ask them to share it with you later, but you can, if you jot it down, you can find it easily on the internet. Okay, and it looks at functional impairments in everyday life. And it's also a parent report. Criterion C, I said it sort of focuses on when the symptoms began. And usually, even if the diagnosis comes later, we see signs from infancy or early childhood already. And this might be delayed milestones, clumsiness, difficulty with age-appropriate tasks. And so a developmental history and tools like the listening for DCD-Q, listening for DCD guide can help us build this timeline. DCD is a diagnosis of exclusion. Okay, this means we must rule out other causes like intellectual disability, visual, etc. Okay, and so this is a message for all our doctors listening in. If a child sort of passes the test of not having any sort of specific neurological or other condition, we can refer on. Okay. Neurodiverse conditions co-occur at high rates. Okay, so I must say we are trying to exclude things, but yeah, you can't exclude other neurodevelopmental disabilities because comorbidity is the norm. Very, very rarely do these conditions exist on their own. So in most cases, if someone has one neurodiverse condition, they're more likely to have at least one other, okay? DCD particularly rarely exists on its own, and around 40 to 50% of children with DCD also have ADHD, okay? Many of them, like I said, they've got, it's not just about the clumsiness, they also have learning disabilities, okay? So like dyslexia or dyscalculia, and recent research shows that, so many children with autism also meet the criteria for DCD. And so these overlapping conditions make the diagnosis so much more complex, but also more important, okay, to identify all the little things that are going on. All right, time check. We into the last bit on interventions. The good news.
5 to 6 more minutes, Jill.
Okay, right, this is where we end. So the good news is that treatment helps, okay? It's not about fixing the child. Yeah, it's like in autism or ADHD, not fixing the child, it's supporting them to move and to learn and to participate. Participation is so important. And the goal is to help them succeed in their daily lives. So my message to the GPs and pediatricians about intervention is really sort of around assessment to support the therapists in terms of making the diagnosis and really sort of dealing with that criterion D. If possible, physical motor examination should be part of your standard assessment. I'd like to see a DCD-Q in every pediatrician's office, making people as familiar with this DCD-Q as others until something better comes along. That's what we have for now, possibly. And, you know, I know you're saying it already, but prescription pads for functional activities, for fitness training, for exercise, for movement. Yeah, that is what our pediatrician has constantly promoted, and that's been fantastic. There's I can't remember where I heard this, but I put it in like just now before the presentation. I don't know where I heard it, and maybe one of you will know that they're saying a GP should have a tennis ball. Every GP should have a tennis ball in their drawer, and this tennis ball can be used to assess DCD, okay, because you're going to pick up lots of throwing and catching, you know, very complex motor tasks, and not your standard, you know, developmental gross motor activities. The therapists, treatment helps. Whatever you're doing, it's going to make a difference. Anything is better than nothing. That said, we need to look into the literature, and, you know, you need to compare and see what results you're getting from different approaches. So what works really well is to use the principles of motor learning, okay, where the child gets to practice functional tasks in their daily routine. Practice and treatment must be intensive, okay? It must be repetitive and variable. Therapy once a week is probably not going to cut it, okay? If you're wanting to improve something, the frequency has got to change, and you've got to repeat it. Cognitive strategies works well with these kids, okay? Think, plan, and do. Of course, perhaps children who have comorbid conditions might struggle with that a little bit. So again, using cognitive strategies where it's appropriate. Practice in context, increase the difficulty level incrementally, and reduce support. In the last 5 minutes, just to address parents and teachers. In the early years, it's all about movement experiences. Okay, kids need supportive, stimulating environments where they can explore and learn through play. And we need to be patient and encouraging, especially when they struggle. It's not about pushing performance, but making them feel safe and confident to try, so you avoid getting trapped in that vicious cycle. For preschoolers, we focus on daily living skills, dressing, brushing teeth, helping with chores. It builds independence and gives them a chance to practice motor skills. Okay? Also provide them with opportunities to move at home, okay? Through play, maybe joining a structured program like a monkey gymnastics or fuzzy fun or whatever else they offer at these creches and schools. And, you know, give them exposure to trikes and bikes, scooters, balance beams, you know, where possible. Start building pre-writing skills and manual dexterity. Activities like beads, clay, and scissors help. But we also need to strengthen the whole body, right? So balance, core strength, and coordination all help to support fine motor skills. In your 7 to 12-year-olds, I'm not going to read everything on the list. Prioritize what is most important for the child and prioritize their well-being and confidence. From there, you want a happy and healthy child. And I think I'm going to, if I don't have any more time, Roshaan, I will leave it there. I was going to say a little bit more about sort of very specific physiotherapy and occupational therapy-based approaches, but maybe we can leave that for the questions.
Yeah, I think we will upload your presentation maybe to our website. So
yes,
anybody is interested, they can always go back to the presentation and just have a read through.
Absolutely.
Yeah, we have quite a few questions.
Yes.
So I think we can just go straight into that, if you don't mind.
Okay, sure.
There are a couple in the chat. You will be able to see it in Q&A. And the first one, firstly, where can we purchase the DCDQ?
Oh, it's available. There's a website. It's called, if you go log on to DCDQ, you can get it. And I don't think there's any cost associated, if I'm not mistaken. It's free. You can download it. You do need to let them know if you're going to be using it for research purposes. But other than that, for your clinical use, you can use it.
Okay, awesome. And
Just
then
remember, again, it's not validated for the SA context, so you will see some items on the list that is not, but at least it starts the conversation, right?
yes, that's right. I mean, even the MABC and the BOT, like you were saying, not for South African context either, but we need to have something that we can,
Yeah.
work from. Then the other question is, can it be that the child that doesn't move a lot is difficult to do so? There's an absence of neuromuscular issue, so you'd miss the obvious characteristics.
Move a lot.
Yeah, so the child isn't moving a lot, but there's no neuromuscular issue.
Yeah.
You'd miss the obvious characteristics. I think generally these children, they compensate,
Yes.
if they're having the physical challenges, they become the bookworm, they become the whatever else in the class, so that they're not called on to do the physical things. And coincidentally, my master's was on DCD as well.
Yeah.
And because I myself can relate, my daughter's also DCD. And I see that in lots of children. They struggle physically. They're the last ones to get called into to join the team. So they just find other things to do. And those are the ones that we often miss.
That is so true. Definitely.
Yeah, there's another question. Tell us about prevalence of poor core support, standing posture, and pronation.
Oh, yes, you're going to find that. I mean, if you, I'm glad that they mention these things. That means you are assessing them and you're looking out for them, because all of them play a role, right? So if you're going to have, especially in the early years, you will pick up, and I mean, maybe some of you parents of children with DCD know this, because I've seen this as well. Your child, their postural stability was just not, even as infants, as babies, not quite up to par, right? And maybe if it was your first child, you wouldn't notice, but later on, you get to know what the tone of a baby should feel like. And so they do get floppy. They do have weak core strength. And this obviously affects their posture. You can't help, but it definitely affects their muscle strength. So that's right. And they're going to drop arches as well. It's all linked. Some of them, actually, there's a huge link also between generalized joint hypermobility and DCD. Okay, so that is what you're going to also see. Okay, it's in the joints. They have poor proprioception, loose ligaments, and that type of thing.
And especially they're not physically doing anything else. They're not working on strengthening their bodies, not the muscles, the ligaments, or anything else. So it's just a vicious cycle. Yeah. A lot of the questions have actually been answered, but I'll just go through them quickly so that people don't feel I didn't ask their question. So then it's like, how does DCD relate to other developmental disorders you spoke about? The link between DCD and ADHD was also covered.
Yeah.
Then the DCD and autism you also covered. And then there's one of, is there a difference between speech disorder and autism? I think that's not for our webinar tonight.
No.
How does DCD impact mass participation in activities and sport? I think has also come through in your presentation. And then sensory integration techniques. How do you think how important is this in managing DCD?
Yeah, so another one that we often get asked. So children with DCD do present with sensory issues, okay? Again, you assess it, you find something, but the research does not support, I mean, and I've looked at meta-analysis of interventions for DCD. And so your deficit-based approaches like sensory integration or kinesthetic training, they don't show a lot of improvement. But that doesn't mean that it may not work in your context. If you are a clinician and you've been using it, it's just that the research doesn't support the use of sensory integration therapy. And it's sort of more, it advocates more for, and again, this is in the physio and OT piece that I skipped, it actually advocates more for a functional task-based approach. So things like task training, the cognitive orientation to occupational performance approach, those are the kinds of physiotherapy and occupational therapy interventions that do have strong evidence.
Yeah. So the one question was also what evidence-based interventions exist for DCD, and I think that is also part of the rest of the presentation you were going to finish.
Yeah, so maybe I can just touch on that. And, I said the co-op, cognitive orientation to occupational performance, a mouthful. Everybody just calls it the co-op approach. It's not something that we're very familiar with here in South Africa. I'm not sure if anybody has been, but you need to be trained to do it. And it was developed in Canada at the ChilD Institute, which is very well known for all their research on DCD. And it is a task-oriented approach, and it teaches the children problem-solving skills. So it has been proven to be effective, but it works better for children who have a stronger, let me think, sort of a stronger cognitive skill based, okay, because it's very sort of thinking about what to do. So you think about it, you plan your movement strategy, and then you do. Whereas your neuromotor task training, on the other hand, is also listed in the European guidelines, in Australian guidelines, as one of the most effective physio and occupational therapy approaches. That works better with maybe a child who has comorbid ADHD or ASD or something else, because it's more related to physical skills. Okay, and it doesn't require too much of thinking about the movement or the activity.
Thank you. There's one question of, can physios and OTs diagnose DCD?
I don't know how to answer that. Because I think here in South Africa, we've got a sort of very multidisciplinary approach to looking at things. Look, if you want to be strictly adherent to the DSM-5 criteria, again, this requires a multidisciplinary approach. So you've got your medical professional who's going to exclude things. And so the diagnosis is collaborative. We all have our role to play in what we bring to the table. Okay, so the medical or neurological people are going to rule out certain things. The occupational therapists are going to come with their assessment. And I would really, really advocate for a multidisciplinary approach to diagnosis.
I think that's easy if you're in a situation like at the school, where you have a multidisciplinary. The problem is that when you have to see all those professionals and you're not on a medical aid, so you have to, go to the day hospital every time, the length it takes to get the diagnosis is...
Oh my goodness.
Yeah.
I hear you. And I know that has been my journey as well. We have started with the diagnosis of ADD, and only when we got to an educational psychologist, in fact, did we get a DCD diagnosis.
Yeah.
And so it is, sometimes you are going to hop from one profession to the next. And, everybody has their value and their role to play. So, let's leave it at that.
Yeah. So I think the diagnosis and management of DCD was covered. How to treat DCD, general approaches, you also covered. And then the characteristics, I think presentation and the treatment for DCD was also covered. But there's one comment here that I think we should maybe I can just read out to you.
Yeah.
As OTs, we see these children and we often see problems with handwriting. So they develop splinter skills and they cannot generalize motor skills to new activities. I've recommended exemption of having to do cursive writing for 2 learners in grade 4. So I found that these children demonstrate poor proprioceptive discrimination. Sensory integration, especially vestibular input, has been impactful alongside the task training and has improved neuromotor performance training. So thank you for that comment. I'm not sure who it is because the name is Tasneem Ibrahim and I know she's a physio, so it can't be her. Okay. There are quite a few Tasneem Ibrahims as well as Roshaan Salie. So if you want to put your name or your question, please do so.
Yeah, look, and then I want to mention what the literature says is that children with DCD can learn. Okay, they can learn, they can improve. It takes longer. Okay, and that is why we advocate for intensive and repetitive. But please, like the person who like the Tasneem Ibrahim had said, sometimes you just have to, if it's not working, apply for the concessions.
Yeah.
Change the environment, change the strategy, alter the expectations.
Yeah.
If it's not about cursive writing, just, let it go. Decrease the cognitive load.
I think Vuyokazi had a hand up, but it's now down. I'm not sure if you have a question, Vuyokazi, for us. Okay. If not, then we have Monique saying, thank you for a good presentation. DCD is also my field of study. I was wondering if you refer your patients to kineticists as well. I know the profession is starting to grow now in Cape Town.
Yeah, thanks for that, Monique. I've spoken, been in touch with many of the kinderkinetica people up at Northwest where they offer the program, and I think they do offer a kinderkinetica program at Stellenbosch. So yes, it's in the same way that the physiotherapists and biokineticists work together in terms of rehabilitation. Kinderkinetica would then be on par to pediatric physio. I'm not too sure, maybe Monique can share the scope of practice differences, but usually with biokinetics, I know that they don't, in the presence of sort of active pathology, they won't sort of get involved there. I may be corrected on that, but yes, they have been involved with children with DCD, and I know they've worked in schools, running movement programs, and also assessing using items like the movement ABC.
Okay, cool. Just a note there that Claire Hubbard is the one who was talking about the exemption of cursive writing. So thank you, Claire. Then there's one on, what is your opinion on mindful movement for adults with possible DCD? Is it yoga? Is it Tai Chi?
Yeah, it's about what you want. What do you want out of it, right?
Yeah, I think it's also what they enjoy.
Do what you enjoy. If it's keeping you active, if it's keeping you movement, it's not getting fitness levels up. So as a physio, I must say, all nice. If you're stretching, wonderful, but DCD, you need to do your strength training, you need to get your cardiovascular fitness. Those are the kinds of exercises I think that will be very beneficial to avoid that physical health problems that often manifest. And I think maybe the yoga and the Tai Chi and that kind of mindfulness things will probably help with the psychosocial aspects of it all. Yeah.
There's just our last comment is that the most useful comments were unfortunately at the end when we didn't have enough time. So please will you add the most useful evidence-based therapies for physio and OT interventions like task orientation, DIR, floor time, cognitively based management as a slide. Okay. Some of our physios are so focused on SI therapy that opportunities are lost in therapy.
Yeah, look, like I said, the two slides that I wanted to share was the deficit-orientated approach to treating DCD. And those include your approaches like neurodevelopmental therapy, visual motor therapy, which is what's often used. I know my daughter's at iGym, if people have heard of that, by a developmental optometrist. Yes, development. So they do visual motor training. There's SI, there's perceptual motor training. So all these sort of treating that underlying deficits and hoping that would lead to improvement in like the performance of the entire system. Again, the research has shown that whatever you do is going to it's going to help, right? You're going to see an improvement. But empirically, from a research perspective, it is your task-orientated approaches that have the most and the strongest evidence. And these task-orientated approaches really sort of cluster around two major forms of intervention, the one being neuromotor task training, okay, where in the task training approach, it's not sort of seen in terms of deficits of particular sort of subsystems, but we look at the problem in terms of motor learning and motor control. Okay, so using motor learning as an approach to treatment. And, it works through the process of changing an individual's functional ability and the ability to perform a task by gradually adapting the demands of the task and also looking at the environment. So you work to make things easier. You meet the child where they're at. You work to make things easier and practice, and you slowly build up and you add in more complexity. And the principles of motor learning includes intensive and repetitive training. So these task-oriented approaches work, but I also like the other therapists' take on things that, you know, sometimes you just have to alter your expectations in terms of what you can achieve. And it may be that you need to apply for concessions, you need to make adaptations in the child's environment, buy the Velcro shoes and don't spend time learning the laces, whether you use
100%,
this or
Make
that,
things easy
you
for
know?
yourself. Yes.
Yeah.
I think those are all
life is hard, guys.
I think that we've reached all the questions. I think people are worried now about the CPD points, so they're now all going to Roshaan, Salie, and Tasneem Ibrahim. If everybody can maybe just send an email to SA-ChilD, Vutomi will then make sure that everybody gets their CPD points. And we also have a list of all those who did register. So we'll use your email. Yeah, so that we guarantee that you're still going to get your CPD points. I'm terribly sorry about that. If there's nothing else, thank you again. Oh, wait, sorry, last one. We work on the gross motor development of children between 1 and 12 years. We are allowed to identify DCD, but not diagnose. I bought the movement ABC3 and will conduct a study in 2026 to determine if the norms are more applicable to our population compared to the movement ABC2. Awesome. I also use the PerFit.
Wonderful.
I'm not sure, it says anonymous attendee. Please contact us, anonymous attendee. We would be very interested in your results. And good luck with your study in 2026. If that's all, thank you very much to everybody who logged on. We have 69 participants that are online. I'm sure the others got lost somewhere in the cloud. But thank you to everybody, and thank you to you, Gillian, for an excellent presentation. Please remember to send that email to SA-ChilD, to Vutomi, so that we can make sure that you get your CPD points.
Yeah. So Roshaan, can I just say, like, in the end, I want to just share this slide. This would have been my last slide.
Oh, cool.
Yes, it is DCD Awareness Week this week. And together with some other physiotherapists, we have formed a little advocacy group for DCD. We call DCD South Africa. I'm wearing the t-shirt. And just sort of trying to raise awareness and be a voice for the Cinderella of the neurodevelopmental disabilities.
Awesome. Thank you so much.